So I'm going to, when this comes up, I'm just going to give you a quick overview of the situation in Ireland, and maybe just a little bit of a quick run through and tell you a little bit about the system there. And let me start, first of all, with an overview of the Irish health system. And just to say, we're a little different to the other, to Northern Ireland, to Scotland, to England, in that we have a mixed health system. It's a mixed public-private health system, so it's really quite a different model. But like all health systems everywhere, I suppose, it's expensive. It takes about 25% of our budget, the government's budget, every year. So it gets a lot of attention for that reason. So as I say, it's a mixed public-private model, and what that means is that we have a means-tested system for access to primary care, and above a certain income level people pay. It also means that we have a very strong private health insurance market in Ireland as well. So about 46% of people in Ireland have private health insurance, so it's a little different. At the moment, it's organised around 7 hospital groups. This is the whole health system in Ireland. The health and social care system is organised around 7 hospital groups, where you have at least one major teaching hospital and a partner university as well. So that's kind of broadly speaking the structure. However, in common with all health systems, we like to, it's a permanent transformation and revolution in healthcare. So we're undergoing at the moment a 10-year reform programme of our health system, and it's a programme that's called Sláinte Care, Sláinte being the Irish word for health. And it was set up really to try and move away from this, I suppose, this thing where health becomes a bit of a political football, and depending on the government that comes in, you might have this policy or that policy. And so it was set up as a cross-parliamentary party initiative to try and come up with a vision for how, as a country, we want to run our health and social care system, and something that everybody could sign up to. At least that's the theory anyway. So now there is a change. It's going to be organised now around 6 new regional health bodies, and they're going to be responsible, they're going to be devolved, so they're going to be responsible for organising health and social care directly. And our Health Services Executive, which is the HSE, which is currently responsible for all delivery of health and social care services in Ireland, will have more of a kind of a coordinating and a policy driving agenda. But you'll probably recognise the vision. It's described as Sláinte Care as the right care in the right place at the right time, which sounds suspiciously like our personalised medicine or our precision medicine slogans as well. So there's a consistency there. So that's just a little map just to show you where we are, and that's how it's organised around the region. So that's the way Sláinte Care is going to be delivered over the next 10 years, and we're hoping to move to that model very, very soon. So overall, the overall focus is to move it more towards population-based health planning. The idea is to develop new models of care, expand, as I'm sure these are very familiar themes to everybody, expand community-based care, bringing care closer to home, change the acute care system, moving the eligibility on a phased basis, starting with primary care to universal health care, and that's happening already for distinct populations, so the over 70s, the under 12, so it's gradually moving towards universal health care. There'll be implications for that for our private healthcare market, which have not yet been worked out, so we'll see how that goes. Obviously looking at financial sustainability, looking to address inequities in the public health, acute health system, because the big issue we have really is around access to health, particularly to the public system, and importantly for precision medicine or for personalised medicine to establish a national health R&D forum, and I'll explain why we need that in the next slide. So if we move away from the health system and look at our research system and our health research system, how is that organised? So this slide just gives you a bit of an overview. And again, it's a feature of the system in Ireland that research in Ireland is funded in line with the parent department. So you'll see up there on the left-hand side, you have our Department of Education and Science, which has 2 agencies, the Higher Education Authority and the Irish Research Council. Similarly, then Department of Business, Enterprise and Innovation has 3 enterprise-oriented research agencies, SAPHIRe and Enterprise Ireland, IDA SAA is less to do with research. As you know, it's to do with industrial development. The Department of Health then has the Health Research Board, which is my agency, and supports obviously the HSE as the healthcare delivery body. And then there's a number of other government departments. So research is funded down through from the parent department down through to the agencies. And I suppose that can lead to a somewhat fragmented system. We don't worry so much about that very often because we're so small. We all sort of know each other. We all end up in the same room anyway. But nevertheless, it's not maybe the best approach when it comes to actually coordinating research. And you can see that in the context of health research, because all of those agencies that I mentioned up there all fund health research in Ireland. The total budget for health research is about for research is about 750 million a year in Ireland. And of that, about 150 million is spent on health research. The Health Research Board would have about 50 million, and the other 100 million then is distributed around. So it does mean that planning and coordination is quite important. So hence the need, as I mentioned in the previous slide, for a national research and development forum, and that's in the process of being set up. Now, I won't dwell on this one, but just to point out as well that those research funding agencies tend to fund according to their remit. So you'll find the enterprise agencies are funding much more around the innovation side, or around maybe the applied research side, in the case of SAPHIRE, around the basic and the discovery-based research. And then the Health Research Board sort of is plunked there in the middle, and we sort of have very much of a focus around clinical research, health services research, and population-based research. So I suppose you can argue that it's a kind of it's a structure that kind of comes about almost organically because of the nature of our parent departments. We tend to fund different types of health research. Okay, so just focusing specifically on the HRB, because that's the agency that has primary responsibility just for funding and supporting health research. We're a state agency under the Department of Health. We have a budget of about 50 million at the moment a year. It's gone up a little bit from that. Funding portfolio between 150 million and 200 million. But we have three different functions. We're not just a funding agency. We also provide evidence for policy for the Department of Health. We have an evidence unit that does specific policy briefs for the Department of Health. We manage a number of large-scale information systems, particularly in the areas of drug use, disability and mental health, and then we also work as a funding agency as well. And we don't fund necessarily or specifically according to disease areas. We fund across all health research, so clinical, population health, health services research, and we do that through infrastructure, capacity building and projects and programs. The only area of research that we have somewhat moved away from in recent years is the more discovery level, basic oriented research, and that's maybe picked up by some of the other agencies. So what are the main issues for clinical research in Ireland? And if you think about it in terms of implementing personalised medicine, obviously these are probably issues as well. But particularly in Ireland, we have invested over the last 10 years, last 15 years, quite a lot into clinical research. Our clinical research infrastructure 10, 15 years ago was quite underdeveloped, so we've made a big effort to bring that up. It's still relatively new, so that's, I suppose, worth saying. It's also important for clinical research in Ireland at the moment. A lot of the funding does come from funding agencies, charities, philanthropic sources. The HSE does not, this is our health service delivery, our equivalent, say, of the NHS in the UK, doesn't have a dedicated budget line for research. In fact, they actually do spend quite a bit on research, but they don't actually pull it out into a separate budget line. So research, as I say, is mainly funded through agencies with some private funding, charities and industry. I think it's fair to say the links between hospitals and universities are still somewhat under development, though they are strengthening. We do have an issue with limited protected time for research. I don't know if this is a universal problem, but certainly in Ireland for our healthcare professionals, you know, carving time out of their day to do research is always a bit of a challenge, and they're always under service pressure. I suppose the good thing about it is that the research governance in our health system at the moment is currently under review. So the HSE is actually developing a research strategy, which is going to hopefully address maybe some of those issues. Now, I'm not going to dwell on this one because I think you all know it, and I think it's been covered anyway in the previous slides, but the context of personalised medicine, as you all know, it's around the technology and all the drivers there, different approach to healthcare. We're looking at sustainability of healthcare systems, societal expectations, which are definitely changing to the point where we have much more, I suppose, informed and engaged patients and also opportunities. So I think there's no need to dwell on those. But I suppose taking that in mind, the government in Ireland has been very conscious in the last few years of the drive towards personalised medicine. And I think that there's a widespread acknowledgement from the Department of Health, from the Minister of Health, from the health system itself, that we need to develop a national genomics medicine strategy. So about a few years ago, 4 or 5 years ago, there was a review of genetic services in Ireland following a few problems that arose, and that was reported on back 2014. And that resulted in setting up of a national genetic and genomic medicine strategy group. And they made a number of recommendations, and particularly they recommended a networked approach so that we would establish a national genetics and genomics medicine network in Ireland, and that we would appoint a national director to that. And that's just in the process of happening at the moment, and hopefully we'll have an announcement on that fairly soon. And that will be a joint health system university appointment. Separate to that then, obviously appointing a clinical director for genetic and genomic testing. Once those are in place, then the plan is to start actually putting that strategy together, and that's planned to start in 2020. So we're hoping to make fairly rapid progress on that. And that research and development, that health research and development forum that I mentioned that is being established, hopefully will will play a big role in pulling that together. And importantly for this is, what is the scope of any genomic medicine strategy? Is it research? What do you put actually at the centre? And the Department of Health has been very, very clear that it's the patient at the centre, and therefore it's the healthcare system at the centre, albeit obviously working in partnership with the research community. So the scope is going to be, or is, healthcare and R&D. And some of the points that they're considering, and again, I think these came up in the context of the presentation on Scotland, very clear value for healthcare system and patients. So I think that's, if we want to implement genomic medicine into routine clinical care, we need to be informed by that, by clear sense that there's a very clear value. The rationale for public and private investment, and particularly clarity on roles, responsibilities and governance. And there's a very, I suppose, a sensitivity to the fact that there has to be strong private sector involvement in personalised medicine. If you just look at genomic testing and genetic testing and so on, you're going to have private sector involvement. But to be absolutely clear about who's responsible for what and what is the governance around that, and there's quite a degree of sensitivity around that, particularly in relation to data privacy issues and so on. It needs to be informed by realistic evidence on cost effectiveness and sustainability. There is always the concern that you'll end up with something that's very effective but maybe also very expensive and only benefits a very small number of people, and how do you balance that against the drivers for population health and population health-based approaches, legal and ethical considerations. As I said, there are implications for biobanking and data infrastructure, which we're just putting in place as well, and the whole issue of public acceptability. And we're very conscious in doing something like this that we want to bring in the citizen's voice and to build that in as well, so to have some very, very strong role for citizen engagement in developing the genomic medicine strategy. However, that says maybe, so that's what's happening nationally in Ireland, but we have been involved very closely in a number of EU, or we continue to be involved very closely in a number of EU initiatives, particularly with the SAPHIRe group, and so I just wanted to make some mention of that. And again, you'll probably be aware of this, but under Societal Challenge 1 in Horizon 2020, there was some analysis done of projects between 2014 and 2017, and I think they looked at about 350 projects, and they were looking at the domains and the attributes that were relevant to those projects. And you can see that personalised medicine is a driver for I suppose well over half of these, or nearly half of these, about 140 of these projects, 300 projects or so that were looked at, personalised medicine was the main driver, with public health coming up second. And again, if you look at that by disease, if you were to take those 140 projects and look at what diseases were focused on, in personalised medicine. So this is European Union funding going in between those 3 years, 2014, or 4 years, between 2014 to 2017. You'll see, not surprisingly, that cancer takes up the most of those, and that's not surprising, and we've heard some very nice examples already this afternoon. But you can see that obviously there's a spread across other disease areas as well. And we've done that same analysis for our own spend in the HRB, and found, again, not surprisingly, that our own spend on personalised medicine research over best part of 10 years is exactly the same. So a lot of strengths there in cancer, and maybe a little less in other areas. So I just want to mention a few words about ICPermed, because we've been very strongly involved in that. And as you know, SAPHIRE is one of the ICPermed, I suppose one of the initiatives that is incorporated into the whole ICPermed family. And I just want to explain where that all came from. So given that there was a significant spend by the European Commission through Horizon 2020 on personalised medicine research, and given the spend that is going on all around Europe in different countries, there was a feeling that this probably needed to be coordinated in some way at European level. So there are a number of milestones that led up to that, and I won't go through all these, but a number of workshops and so on. And I suppose the big one there was in 2013, there was establishment of PERMED, which was the CSA, and they were tasked with coming up with a strategic research and innovation agenda for personalised medicine, and that was published in 2015. And out of that, of course, it came up with a number of ideas for what needed to happen, and people said, yes, that's fine, but you need some kind of a vehicle to drive all of this forward, and you need some kind of a model to make sure that things happen. So hence, ICPermed was established in November 2016, and I suppose it came out of those commission initiatives and all of those commission that commission investment, but it's very much a member state driven consortium. The aim of it overall is to coordinate and foster research and to develop and evaluate personalised medicine approaches. Well, that's pretty broad, but it involves about 35 European and international partners. So anybody's eligible to join the consortium, provided they're a public funder of personalised medicine research. So it represents ministries, funding agencies, and the European Commission as well. And it follows an international consortium model. I don't know if any of you are familiar with the Rare Diseases Consortium, but it follows a similar model to that. And overall, the aim is to try and across Europe and across these different funding agencies to identify common strategic goals, try and share tasks and goals. There is no particular funding. ICPermed itself doesn't have a pot of funding, but the individual members obviously have funding streams. And so the idea is that they would fund research according to their own funding rules, but they would do so lined up or align themselves with the goals and the objectives of the consortium. And overall, the aim is as much as possible to share results, share data and standards, and very importantly, to share examples of best practice, which is also what you're doing over the next couple of days. The first thing, I suppose, that came out of all of that was an action plan, and this was mentioned already, which was published in 2017, and that identified a number of specific actions that people could take on board, either at national level or between groups of countries or at European level. And it's used to inform our strategies. I'm not going to go through all of this, but there's a number of initiatives that it's involved in. There is a funding stream, an ERAnet called ERAPermed, which many of you are probably involved in, and that's had a number of calls already. And those funding calls are informed by the themes in the action plan. It has a partnering tool, which you might find useful if you want to check it out. It's on the ICPermed website, and the idea of that is that people can put in their own contact details, their areas of expertise, if they're searching for partners, either for the ERAnet, the PERMED ERAnet, or for any funding, you can go and look for a partner. It has held a number of workshops, one in 2017, which is focused on data in particular. The one last year focused on personalised medicine in action, which was all about best practice examples, and they're all up on the ICPermed website. And the one this year, which is coming up next month, which is looking at implementation into the health system, or into health systems, and maybe some of you are attending that as well. And just one other thing I didn't put up, they do run every year kind of a competition for a prize for the best practice, the best of the best practice examples in personalised medicine research. So if you want to nominate your colleagues or nominate yourself for that, they're always looking for nice examples of best practice. So Overall then, I suppose SAPHIRe is to some extent, it's an umbrella initiative, and you can see all the other things that are going on here on this slide. A number of CSAs, the SAPHIRe Secretary itself is a CSA, and of course we have SAPHIRE here, and we have others that are focused. That one there is, there's one on promoting cooperation with the Latin and Caribbean countries. There's one focused on healthcare, on economics, on health economics and pharmacoeconomics as well. So there's a number, and there's a number in the pipeline. There, one that Ireland is involved in as well, which is the EU-China one, which is promoting links between the European Union and China in the area of personalised medicine. And then over on the right-hand side, you can see there are a number of other initiatives, including the Million Genome Project, or the Million Plus Genome Project, as they're calling it now, because they're saying a million isn't enough, which I know a number of countries are signed up to as well. So there's a lot going on, and I suppose the idea of SAPHIRe is to some extent to try and bring some sort of coordination to all of this so that we have a reasonably structured and coherent landscape. Okay, I'm not going to go through all of these because I know you want your coffee. And just to mention as well, and I think Tony might have mentioned it, the vision paper, which has just been published, which sets out a vision of personalised medicine and how it can be implemented by 2030. And that's just been published in September. And again, they're I think Tony mentioned these, so I'm not going to go through them, but they're the different parameters and the different perspectives that are set out in that vision paper. Okay, so I just want to mention before I finish, because I know you want to have your coffee, while all this is going on, we do have a number of best practice examples ourselves, or things that we hope will become best practice examples in Ireland. And I just wanted to mention two things, one of which has just been funded, and you may be interested in, and this is an SFI centre called Future Neuro. SFI is our sister agency, and they've invested quite a lot actually in this new centre. And this is all about looking at neurological disorders, focusing initially on epilepsy and motor neuron disease. And the problem here is 1 in 4 people in Ireland affected by neurological disorder during their lifetime. So building again on very significant advances, as we've all heard about in genomic medicine, the fact that the cost of sequencing has reduced, all the recent advances that we know about, molecular therapeutics and biomarkers, and particularly on the fact that we have a very nice epilepsy electronic patient record, which has over 10,000 people, which is a longitudinal cohort. We've been following them now for quite some time. It was actually set up and funded by the HRB many years ago, so this is a nice example of interagency cooperation. And they have information obviously on things like compliance and quality of life, severity of seizures, all of that sort of thing. And they're now also going to start collecting, obviously, along with the clinical and phenotypic data, they're going to start collecting the genomic information as well. So this is what Future Neuro is about, and it's also supported, I think, to some extent by the size of our healthcare system in Ireland. We sometimes fret about the fact that we're very small, but actually sometimes it's good to be small because everybody knows each other. If it's large enough for relevant results, we have a population in Ireland of about 5 million, which is a little bit not dissimilar to Scotland. But a relatively small number of linked clinicians. So we are able, if you like, if we want to support national collaborations, it does make it a lot easier. So that has just been set up, and as I say, they're going to start with epilepsy and move on, and they also have some very nice scientific research programs in motor neuron disease as well. And the other one I just wanted to mention was the TAILOR-X study, which was a large-scale clinical trial, which was supported by Cancer Trials Ireland. And unfortunately, my colleague from Cancer Trials Ireland would like to have been here today to give you more details on it, but she wasn't able to come, but I'll just mention it. So this was all about trying to address the problem of which patients with early-stage breast cancer are more likely to benefit from chemotherapy. And again, you may be familiar with it. So this was a very large-scale trial, and we take the point that trials are changing, and now you're moving much more towards more targeted, smaller trials, but nevertheless, over 15 years, this was over 10,000 women, 690 of whom were recruited in Ireland, and that Irish arm of the trial was coordinated by Cancer Trials Ireland. And basically what it was all about was trying to examine methodology for personalising post-operative cancer care treatment. And using that particular 21 gene expression test, they were trying to identify which women needed to follow up treatment with chemotherapy and which women didn't. So they were able to identify through that about 70% of women with low risk of cancer recurrence after surgery could avoid chemotherapy. Now that test has now been fully integrated into clinical care in Ireland, and so it's routinely offered as part of clinical care. And I suppose the point there, of course, it has generated considerable savings for the HSE because they're not wasting money on unneeded drugs. But most importantly of all, I suppose it has generated considerable savings in terms of distress for the women involved, who have been able to avoid what is, after all, quite unpleasant and distressing, and as it turns out, quite unnecessary treatment. So I think that's what, in the end, we're all about with personalised medicine. So I'm going to leave it at that. Just to say, in summary, our healthcare programme, our healthcare reform programme is underway in Ireland, so it's a question, I think, of watch this space. We will very shortly have a Director of National Genetics and Genomics Medicine of that network being appointed, and then we'll be moving towards developing a national strategy in 2020. We have, despite all of that, I think, very good European and international engagement, and it's certainly a pleasure to be here today. And I think while all of that's going on, we continue to have some very nice, good programme level examples of personalised medicine research and their links and their implementation into the healthcare system. So thank you very much indeed for your attention.